So typically what we think of a neonatal baby is from birth to about 4 weeks of life. So kind of that first month is what we start considering about neonatal dosing. So anything above that we start considering, especially if it's somebody who's just been born but they're already past a month of life. That's the point in time when we start thinking about switching over to possible changes in dosing if it does require dose alterations. But we do have those patients who are only they're born at 26 weeks when a normal baby's born around 38 weeks. And so even if they are, a month old, they kind of still fall within that post-menstrual age of 31 weeks. So at that point in time, it's kind of difficult to say. But yeah, so about a month of life is when we start thinking about pediatric dosing. That's when we start thinking of considering them like infants. Good question. So then we'll move on to our next patient case, but very good questions. So our next patient is 8 years old, who weighs 34 kilograms, and they present with an asthma exacerbation. And specifically for patients who do present with asthma exacerbations that require hospitalization, one of the treatments and one of the therapies that we do want to administer just a couple of days is corticosteroids. And so most often prednisolone for our case. And so the medical team would like to prescribe prednisolone here, given at a dose of 34 milligrams, given every 12 hours. And so the ordered milligram per kilogram dose for this patient would be just about 1 milligram per kilogram per dose exactly. And so they would be receiving 2 milligrams per kilogram per day. And so from what you can see in Lexicomp, from what you can see, do you believe that this is an appropriate dose? And if not, what would you want to prescribe or recommend? Any thoughts on this medication?
It's appropriate.
Okay, yeah, so I agree the milligram per kilogram dose is appropriate. However, this is one of those scenarios when we're actually getting into the patient is starting to weigh a little bit more. And so we start thinking about the caps of medication. So if you do look under Lexicomp for this indication, and if you do look under adult dosing as well, we see that there's a cap of 60 milligrams per day. And so we would actually not want to exceed 30 milligrams per dose every 12 hours. But good thought. So this is an appropriate milligram per kilogram dose. And so from, I don't know how many of you work I'm not sure how many of you work in an outpatient setting or what experience you have with dispensing prednisolone, but what sort of concentration do we have available for prednisolone? Yep. So it's available in a 15 milligram per 5 ml concentration. And so based off of this fact and doing just a little bit of math, so 30 milligrams and a 15 milligram per milliliter concentration would give us 10 mLs. And so this is relatively easy for the parent or whoever the caretaker might be because it's going to be full 10 milliliter syringe. All right, so now we're stepping out of the realm of assessing if a dose is appropriate, and now kind of getting into the realm of when a medical professional actually asks your opinion as a pharmacist for your recommendations for dosing of medications. So we do have a 3-year-old patient here who weighs 14 kilograms. And the doctor, they're having fever, they're fussy, they want to schedule some oral acetaminophen. And so what is an appropriate milligram per kilogram dose for a 3-year-old patient? What can you guys find? Yep, that's perfect. So the recommended dose is 10 to 15 milligrams per kilogram. And so there are several medications that I see on a daily basis that just, I can recite them off. So it's 10 to 15 milligrams every 4 to 6 hours exactly. So the total milligram dose for this patient would be 140 to 210 milligrams. And so based off of available concentrations or what sort of products that you can actually find in Lexicomp, what would your recommended dose be? What would the volume amount that you would want to give? I think I might have heard a 1 160 somewhere. But we do have an available product here in the hospital. It's just a unit dose cup that's 160 milligrams per 5 ml. And so this would be an appropriate dose for this patient. And so frequency, we already had a frequency that was noted for us. And so it's every 6 hours for this case. And so one of the things that we want to think about specifically with Tylenol and certain other medications is not exceeding a total daily amount. And so for Tylenol specifically, we don't want to exceed 75 milligrams per kilogram per day. There is discussion in whether 90 milligrams per kilogram per day would be appropriate. And then our heavy patients, we don't want to exceed that 4 grams that we would normally do in an adult patient, especially for a heavy child. So a frequency of every 6 hours would be appropriate for a in between 10 to 15 milligram per kilogram dose. So any questions about how we got to that? Okay. And so we'll actually have another Tylenol question, so we can kind of refer to what sort of dosing that we are familiar with. All right, so next up, we have a 14-year-old patient who weighs 57 kilograms who presents with methicillin-resistant Staphylococcus aureus, or MRSA pneumonia. The medical team would like to prescribe oral clindamycin. And now thinking about this patient, so they are 14 years old and they are 57 kilograms, so they're kind of getting to that point where they might be considered an adult, and we want to start thinking about dose capping. And so what is the appropriate milligram per kilogram dose for this specific indication?
To 16 milligrams per kilogram.
So you should be seeing about 40 milligrams per kilogram per day and having this dose divided about every 6 to 8 hours. And so based off of this fact, what is the total milligram dose that we would want to administer for this patient? And I will say ahead of time that typically we try to not dose oral clindamycin very frequently. We want to avoid some side effects with oral clindamycin. So most oftentimes we're going to resort to the every 8-hour dosing. And so taking that into account, what would the dosing be for this 40 milligram per kilogram per day divided every 8 hours or 3 times a day?
Would you do the maximum dose of 600 milligrams every month?
That is absolutely correct. So we know that 40 milligrams per kilogram multiplied by this patient weight is just over 2 grams. And so if we divide that every 8 hours, it's going to give us a dose of 760 milligrams. However, if we look at the adult dosing specifically for pneumonia, we can see that it's capped at 600 milligrams every 8 hours. So that is absolutely correct. That is the dose that we would want to go with. And so what sort of dosage form now? So thinking about this patient's age, thinking about what sort of dose formulations or routes of administration that we have, what dosage form would we actually want to recommend for this 14-year-old, so a teenager patient?
Can we use the 300 milligram capsules?
Absolutely. So that would be my recommendation as well. So 300 milligram capsules. So for this specific patient, we could just have them swallow 2 capsules for their entire dose. Again, 14-year-olds isn't extremely old, so they could swallow it separately, but I do think it would be appropriate to do the capsules. So any questions on how we arrived to those answers? All right, moving on to our next problem. So we have a patient who is 9 years old, who weighs 28.6 kilograms, who presents with a skin and soft tissue infection. So some sort of infection to either their dermis or some sort of kind of external body part. They want to prescribe sulfamethoxazole, trimethoprim, or Bactrim orally. And so what sort of dose would you want to give for this patient in regards to milligram per kilogram?
8 to 12 minutes per kg.
Yep, so I'm hearing some 8 to 12 milligrams, and specifically of the trimethoprim component per kilogram per day divided every 12 hours. And so the total milligram dose, if we go based off of this fact, would be 228.8 milligrams to 343.2 milligrams of the trimethoprim component per day. And then divided every 12 hours, this would be 114.4 milligrams to 171.6 milligrams given every 12 hours. And so what sort of routes of administration, or what sort of formulations can you see if that would be appropriate for this patient? Or what sort of concentrations of liquid do we have available?
milligrams, 540 milligrams per 5 mil.
Okay, so I found a suspension that was available as 40 milligrams of the trimethoprim component per 5 mLs. I'm not sure if the 200 is an available suspension as well. So based off of this fact and knowing that we have this range of concentration and range of dosing, how many milliliters would you guys want to recommend for this patient? So I will say that it falls somewhere between 14.3 milliliters and 21.45 milliliters. And so again, there's not an absolutely right answer, there's not an absolutely wrong answer. However, I would recommend doing 15 milliliters, which would put us at a dose of 4.2 milligrams per kilogram given every 12 hours. But I think it would also be appropriate to do 16 milliliters every 12 hours, 17, 18. It just depends on what your personal opinions on this fact. All right, moving on to the next question. So we have again, an acetaminophen question. So we have a 1-year-old patient who weighs 9.4 kilograms, and they're presenting with fever, they're presenting with fussiness, and they're also presenting with emesis. So they are not able to keep anything down. And so mom's trying to feed them, mom's trying to give them ibuprofen, acetaminophen, and they're just throwing everything up. So the medical team would like to prescribe or recommend some acetaminophen. And so what would your recommendation be for the milligram per kilogram dose of Tylenol? So what was that dose that we had referred to earlier? Yeah, so it's going to be that 10 to 15 milligrams per kilogram. And so based off of the patient's weight and based off of this recommended milligram per kilogram dose, this would be 94 to 141 milligrams. And so based off of this patient's clinical scenario, so knowing what sort of issues they're having, what are some other formulation options that we do have available to us?
Suppositories.
Yep, so we have suppositories available, and this would be our most appropriate dosing for this patient. And so suppositories do come in readily available products that range anywhere between 80 milligrams to 650 milligrams. And so what would your recommended dose be for this patient?
$120 milligram.
Yep, I would do the same thing. I would do the 120 milligrams every 6 hours, and then as needed for this patient's fever, as needed for this patient's fussiness. And so a lot of people don't realize, especially for patients who do have difficulty keeping anything down by mouth, that we do have these other formulations available. A lot of times in the hospital, they want to go straight to IV, give them some morphine, give them some ketorolac. But we do have these rectal suppositories available that work just as well as oral medications. All right. Thank you for bearing with me through those. Any questions about those or how to address those or what sort of things to think about for those specific patients, for those specific problems with dose rounding, with syringes, anything? Okay. So now we'll move on to actual prescription filling. And so this might not be as relevant to you right now. However, once you get into your 4th year and once you start thinking about getting licensed, and specifically in Georgia, and I think still in New York, there's a portion of the licensing exam that is a wet board, and I think you guys have already had some, I'm not sure with the new curriculum, but had some medication error type of quizzes and tests where you actually assess the prescription, you assess how the prescription was filled, so the appropriate stock bottle, the appropriate actual product to begin with, and also the label. So this will be extremely relevant for you very soon. So what we'll do is we'll actually look at some prescriptions. We'll see if you feel comfortable filling them. There's a couple of options in regards to the reasons that you would not fill them or if you want some clarification from the doctor. And so if it would be a prescribing error, So if this would be actually something wrong with the prescription from the doctor, if something's not making sense that you do want to clarify with the doctor. If it is a filling error, so if there's some issue with actually filling the prescription, so if it's a wrong medication, if it's a wrong strength or anything of that nature. If it's a labeling error, so if there's actually something physically wrong with the label, so if the name on the actual prescription is different than the label on the actual prescription bottle or an IV bag. Controlled substance, so if there's something wrong with the controlled substance law, so whether this be an inappropriate amount that's being prescribed or it doesn't have the appropriate sections in the actual prescription. Improper substitutions, so the thing that most comes to mind are brand necessary prescriptions and you're filling it with a generic, or if it has no errors. And so we'll move on to our first prescription. So we have a 20-pound patient who presents with an ear infection, and Dr. John Smith would like to prescribe Janie Woodley amoxicillin, and this is given at a dose of 1 teaspoon by mouth 2 times a day for 10 days. And so do you guys feel comfortable filling this prescription? Would you want some clarification? What are your thoughts on this medication?
Concentration of amoxicillin.
Yep. So we have an issue of a missing strength or a missing concentration. So we don't know how much we're giving to this patient with this 1 teaspoonful. So we have a 23-kilogram patient who presents with pneumonia. Dr. C.O. Jones would like to prescribe Joseph McIntyre with azithromycin at a concentration of 200 milligrams per 5 mL. And the dosing is kind of your typical Z-max dosing. So with this specific medication and this specific prescription, would you feel comfortable filling this prescription? Would you want clarification? So personally, I would feel comfortable filling his prescription. I didn't see any medication errors on this. But I do know that feeling when you think there's probably something wrong, but you can't find it, and you don't want to put that answer of no errors. I can tell you will absolutely experience that if you get licensed in Georgia. You will experience that on the licensing exam. I didn't have any exams that had actual products to check, but any questions on prescriptions specifically for pediatric patients? So now we'll move on to medication administration techniques. And so one of the unique things about pediatrics, and I guess possibly geriatrics, the opposite end of life, is that we do have different age groups that do have different requirements into what they are capable of in regards to taking, whether they like the medication and they're actually going to swallow it, or if the bad taste is going to be spitted out. So we'll go over just some general medication administration techniques all the way up from infants to children and teenagers. And so for infants, it's recommended to give oral medications kind of that time around feeding so that they are kind of ready to take something by mouth. Positioning the baby in a semi-upright position, and so kind of, again, in that feeding position. And then one of the things that is recommended that you kind of give it not directly straight into the back of the mouth, but administering it to the side of the mouth alongside the gum. If you administer it straight into the back of the throat, you can imagine what sort of problems you might have. The baby might spit it up, it might aspirate, get into the lungs, they might not take the whole amount of the dose of that medication. So it is recommended to give small amounts of that medication, so it's particularly large volume. So giving a smaller dosage of that medication kind of in multiple increments. And then also not just squirting it straight into the back. And those of you who do have children probably know better than me. So if you have any other insight, please let me know. Toddlers, and so getting a little bit older. So actually having the parent hold the child, being brutally honest with the patient, so telling them that this is most likely not going to taste good. However, it's going to be over soon, and this is going to make you feel better. But then also rewarding them for taking this medication, especially if it's a very poor tasting medication. That can kind of provide that incentive for them to get that dose. Having the toddler actually practice giving the medication to an action figure, to a doll, that can kind of take that fear out of taking the medication. So as opposed to having this oral syringe kind of coming at them from above, actually kind of giving them and having the practice and seeing what it's all about. But then also just general practice, keeping that medication out of reach of those patients. So not only the medications for that specific patient, but also family medications as well. And then older children. And so once they get to an older age, so once they get into their teenage years, I think probably the most important thing that we could possibly be doing for these patients is involving them in their health care. So letting them know about their disease state, letting them know about their condition, letting them know what the medication is doing, how it's going to help them, how it's going to prevent something from happening to them, but then also being realistic about what they might expect from these medications. So side effects, how it might make them feel, how it might taste, and just having them very much so involved in their own health care. And for those patients who are more used to giving oral liquid medications or suspensions, so actually having them practice swallowing kind of bigger or larger kind of pills or capsules or candies to kind of get them used to that. And so any questions about administration techniques or anything that you guys have found in your personal practice that has benefited you if you have kind of a steady pediatric population coming to your pharmacy or wherever you might be? And so now moving on to the actual taste of medications. And so there are different classifications of taste for specific medications. And so there are medications that taste bitter, and so they're just not palatable at all. You can see what sort of medications are listed there. There are foul medications, and so medications, whenever I hear the word foul, I just think of like rotten eggs or something like that. So it's a very bad taste. And you can see what sort of medications are associated with them. I've heard many a kid does not like clindamycin oral suspension, and I guess it's just because of that poor palatability. And then actually salty. So imagine taking a gulp full of seawater, but these are the medications listed below that could possibly be associated with kind of a more salty taste than anything. And so there are some recommendations in regards to counteracting these tastes. And so for those medications that do have a bitter taste, so kind of counteracting those with sweet taste, so having flavored with grape or having them flavored with bubblegum. Foul flavors, so again, kind of just that very poor tasting medication, more so an oil-based flavor, and so those are most associated with like citrus flavors, so lemons or oranges, but then also raspberry. Salty flavors, it's recommended that either grape or raspberry can be flavored for these medications to counteract the saltiness, and so it seems like grape or raspberry, you can't really go wrong. And then again, I don't have a whole lot of experience in the outpatient setting, but I don't know what could be wrong with adding more sweetener. I think you're probably only help these patients and help these individuals taking the medications. And so now we'll move on to drug information regarding over-the-counter products, or what sort of issues you might run into, or questions that you might get more so in an outpatient setting. And so let's start taking a look at these, and we'll just jump right in. So we have a father of a 3-year-old child who comes into a pharmacy and he's just frustrated. He's frustrated that his son won't take his oral clindamycin. What recommendations can you give to this father in regards to how he could possibly make this administration easier for his little 3-year-old child? So what sort of things can we start thinking about? So we know that it's oral clindamycin. So what could we do possibly to that oral clindamycin?
Offer to flavor it.
Yep, so we could offer some flavoring. So we know that clindamycin is typically associated with like a foul flavor. So if we want to more so have it tasting kind of those oil-based flavors. So again, the citrus, the lemon, the orange, or the raspberry. What are some other things that you could possibly think of that might make administration easier for this patient? And so we also know that he's probably more of a toddler age. So what sort of techniques could we possibly do? Yep, so we could offer them some sort of reward for taking their medication. Also in regards to specifically administration, so avoid administering the medication directly on the patient's tongue. That can help prevent them from having that bad taste. And so again, kind of administering it in a different place in the mouth. So whether that be alongside the gums, whether that be alongside the cheeks. But then also popsicles. If you give them a popsicle beforehand, that can numb the taste buds. I tried to verify, so my wife is a dentist, and I tried to verify it with her if this actually works, or if she has any experience with it. She's not a pediatric dentist, but she had no idea, but it seems correct in theory, and it does seem like it was a possibility. So any other ideas in regards to administration for this patient with clindamycin? Any other thoughts? So we'll move on to the next patient case scenario. So 5 minutes later, after the clindamycin issue, you're working and a new mother calls with a question for the pharmacist. So for you, her newborn son has been spitting up his acyclovir, so having some sort of viral issue that they need to treat with acyclovir, spitting it up after she gives it. So she wants to know if she's able to mix the dose in the bottle of formula so that he can take it with his feeds. And so what would you tell this mother? What would your recommendation be for this mother? So would it be able to be mixed in formula? And after mixing it, what sort of recommendations would you have for her? What sort of thoughts are you thinking of in regards to this?
Finish the whole bottle if she did that.
Do it.
I have to be sure they finish the whole bottle if she
Yeah.
did that.
So that's a very big issue. So over here in Augusta, we had making sure that she finishes the whole bottle if they do mix it in there. And so that's one of the main issues that I did want to address. So if they are putting it in the whole bottle, I don't know if there's a certain way that you can ensure that this child is taking the whole bottle, but you also want to avoid doing that just to ensure that this patient is receiving the most medication that they possibly get in the entire dose. You can also mix it in a small amount of the feeds as opposed to the whole bottle. So just in 5 or 10 milliliters to help mask this taste that apparently this newborn child is not having any flack with. And then you can also administer the small amount of volume, so you can administer it with that syringe or through a nipple top as well. So any thoughts on the acyclovir, this question? Okay. So moving on to our next patient. So 5 minutes later, you have a mother coming in who wants to give Pepto-Bismol for her 3-year-old who has a stomach ache. Yes, question.
What cannot be mixed with formula? Is there a list or something we can find? for
Specific, and so we have a question over here in Augusta, so asking about which medications, which formulations of medications cannot be administered or mixed in some sort of formula or food. So it is very medication specific. So it is something that comes out a lot, so especially for medications that come in a capsule that the kid is not having, he's not being able to swallow, so seeing if there's a possibility of opening that capsule and actually mixing the contents. And so it very much so is medication specific. And so I do think our resources, so Lexicon, should be able to provide information like that, where it can say either, I forget what medication it was, so just yesterday I also spent some time in the transplant clinic, the pediatric transplant clinic, and we had a mother who had an issue with her son not being able to swallow medication and seeing if we could possibly open it and mix it in. I'll try to think of it, and then if I do think of it before the presentation, I'll pull it up on Lexicon. But it's just kind of a one-on-one basis. Very good question, though. I wish there was just a list, but unfortunately there's not. Okay. So back to the Pepto-Bismol question. So we have this 3-year-old who wants to take Pepto-Bismol for stomach ache. What would your recommendation for this mother or caretaker be? Okay, so we have a response over here in Augusta. So there's a question regarding if there's a children's formulation, which there is a children's formulation. So say in this scenario, they want to get just the regular Pepto-Bismol, not the children's formulation. So that should give you an idea of what we would want to tell this mother. And so specifically for Pepto-Bismol, so the regular Pepto-Bismol has salicylate, a component that's a salicylate, and you actually want to avoid the use of salicylates unless it's for a very specific indication. So there are certain indications that you can give salicylates to in children less than 12 years of age. However, you want to avoid just regular use due to the risk of this Raynaud syndrome, which you might be familiar with. But you are correct. So there is a children's formulation. I think it's just Tums. I think it's liquid Tums. I think it's calcium carbonate. But yeah, and so I think that's an appropriate, so if this mother or whoever wanted recommendations into what you could do for this patient, that is a possibility as well. You could try a little bit of calcium carbonate. All right, so moving on to our next problem or question, we have a parent who calls into the pharmacy saying that her child's amoxicillin was left out of the fridge overnight. And so she's wondering if it's still good, if she can still administer it, if she needs another prescription to get this filled. So what would you tell her about this amoxicillin that has not been refrigerated overnight? Any thoughts, any experiences in a community pharmacy that you've had?
Well, I would want to know where she left it out.
That's a very good point. Yeah, so if she left it, in a shower, and the shower's been running all night, if she left it on the oven, I would want to know that as well. So say it's just left out on the counter, just in the kitchen, overnight, so not in direct sunlight. So what would your recommendation be for that? So it should be available in Lexington. Yeah. So over here in Augusta, we have that it is stable at room temperature. So refrigeration is preferred for amoxicillin suspension. However, it's definitely not necessary. And as long as, again, very good point brought up, as long as it's not, left out in a very humid environment, not in, direct sunlight for days upon a time, not, left inside the oven, then I think that this would be appropriate for this patient to continue to receive this medication. All right, moving on to another, I think this is my second favorite question next to that ampicillin for you guys. But a parent wants to know if they should use lactobacillus when their child is on antibiotic. And so for a prolonged period of time, this patient is going to be on some oral antibiotic for one reason or another. And they want to know a recommendation in regards to what dose to give for the lactobacillus. So what are your thoughts on lactobacillus, so having live culture administration for patients, pediatric patients?
The age of the child.
Yep. Yeah, so age of the child is very important. I would feel much comfortable making recommendations for one patient over another, depending on how old they are. So let's say that this is a 3-year-old getting oral clindamycin. So we're thinking kind of more of a younger toddler age patient. And so this is actually a topic that has a lot of heat right now. There's a lot of discussion regarding the use of probiotics, not only in the pediatric population, but in the adult population as well. And so as much as there's not a lot of literature in the adult population, there's even less in the pediatric population. So we do not have a very good answer for this question. We do know that there has not been shown a very significant improvement in regards to the patient's outcomes, in regards to receiving lactobacillus. And if anything, literature shows that there's a slight increase in the amount of infection that occurs when lactobacillus is administered. And we also know that lactobacillus, so it is not a prescription product, so it is not regulated by the FDA. And if we were concerned about administering the lactobacillus for this patient, we could recommend to the parents and the mother to try giving a little bit of yogurt to kind of give that healthy bacteria. So the idea of having that antibiotic kill the normal flora in the GI tract, and then replacing it with some healthy bacteria, so having the mother administer or give a little bit of yogurt. However, if the mother is persistent, if the parent is persistent, there are available products over the counter that can be administered to children. So we have chewable packets, powder that can be mixed with a little bit of food, a little bit of liquid, but there's just not a very good answer for this question. So any thoughts on this? And so it is a practice that I have seen very frequently here in the hospital. We have patients who we are sending home with oral antibiotics, and the medical team either wants to prescribe some lactobacillus or some Culturelle, and there's just really not a good response to them. Just one of those scenarios in pediatrics. So any questions on this one? Any thoughts? All right, so we'll move on to the very last section. We won't spend too long on this section, and then we'll finish up. So we'll get you out of here in just about an hour. So one of the things I wanted you to think about was actually having the opportunity to counsel patients. So counseling parents is one piece, so they're going to be very concerned for their child, but also taking into account counseling the child. So if they do want education for their 6 or 8 year old child, or if you do have a teenager, what sort of challenges that you can approach. So you had a mother and her 3-year-old child come into your retail pharmacy with a prescription of gabapentin at a dose of 3.5 milliliter solution that can be given 3 times a day. What would you guys want to counsel the mother on, or what sort of counseling points do you think would be high points for this specific medication, perhaps in regards to administration? And once you kind of come up with a list, if you want to turn to a partner, and again, we can only take about 2 or 3 minutes for this activity, and then we can kind of come back and see what sort of thoughts that we do have about an appropriate way to measure as well as administer the medication. So just take a couple moments to kind of gather your thoughts, and if you want to discuss with some classmates, you can do that as well. So taking into account everything that we discussed.
What's your mom?
It's the flu. You dying?
There's something going around right now. It's this virus or something that I picked up at work on Sunday. Are you not?
Gross.
I was a little bit yesterday, but it's gone. There's something going around.
And the person
last year. I have to go to work today. I do too.
That's it.
I know. Or it's like the whole monitor for new onset or worsening depression, suicide.
Just tell them they'll probably be drowsy. Won't taste good. And can they give 3.5 mils?
Yeah.
I thought like you could do, and 5 mil was like 0.2. Yeah. What? Yes.
Annoying.
We can go ahead and start bringing it back in. So I heard some really good discussion here in Augusta. So do any of the distance campuses, do they have any thoughts, any ideas on kind of what they discussed in regards to this prescription and this scenario? What would you guys want to recommend in regards to measuring this dose out? So we know it's going to be a 3.5 milliliter syringe that or volume that they're going to be measuring out to.
You could show her on the syringe that you're giving her where the 3.5 is going to be.
Yep. So measuring it out with an actual practice syringe and showing them where it's going to be. I also like to, so this is something that I do on a daily basis when we have patients being discharged, just to make sure that we do have the appropriate dose that we're giving in regards to the volume. So showing them where to pull back to, but then also having them practice to where they can pull back to. We have a vast range of health literacy for our patients and for our parents. So some, I had one mother who actually worked in healthcare. She worked with pediatrics, so she was spitting off side effects of her medications. But then we have others who just have challenges pulling back to the correct volume. And I can see, especially for prescriptions and for medications that, or multiple medications that have different syringes that they're going to be measuring out with, where the confusion lies. So I think that's extremely valuable. So we have measuring, what about actual administration of this medication? So for this 3-year-old, for this toddler, what sort of things could you do?
It's like quite amount of, like a good bit amount of liquid, so just let her know not to squirt it all in his mouth at once.
Yeah, so, and then over here, I guess we have, 3.5 milliliters for a 3-year-old mouth might be a lot for them to handle. So again, administering that dose maybe in smaller increments to make sure that we're not, squirting the whole thing, they're spitting it up, they're coughing, they're aspirating all this junk. Yeah, so very good. And then what about one of the important things, especially for kids, especially for working parents? So what would you want to tell this mother? So say she forgets to give the morning dose before sending their child off to school. And so what would your recommendations be for giving a dose? What would you guys want to do in those kind of scenarios? Is that one time?
Like make sure the daycare worker has some?
Sure. Yeah. So we have a thought of here in the rest of that. So especially for those medications that are given throughout the day, so not just maybe once a day or twice a day. So making sure that the appropriate daycare or school has the medication as well that they can be administered. Yeah. So really good thought. And so what about, so for this case, so say they forgot the morning dose and it's already almost time for their midday dose. What sort of things would we want to consider? What sort of things would we want to tell her? And so also here I guess that so for those doses that are multiple times a day. So if it's already close to the next administration, so just having the parent skip that dose, not having them feel like they need to double up on the dose. So just going ahead and skipping it and getting back on the normal routine. That's something very important to consider. If it's within an hour or so, I think it would be appropriate to go ahead and give that dose and just kind of get back on the normal schedule, whatever works for them. But you definitely don't need to double up on a dose, especially something like gabapentin that does have some side effects associated with it. Okay. And so the last thing that we'll go over, so a patient you have been helping care for in the hospital is being discharged today with a prescription for Argumentin to help clear up an ear infection. So although you've already counseled the parent with the appropriate information, the patient is curious about their medication. And again, so think about some points that you would want to counsel a patient for in regards to Argumentin dosing for a 6-year-old patient, so a toddler, and then a 13-year-old patient. So what sort of counseling points would you want to, kind of the high points that you would want to hit, and how would you explain the medication to them? So again, take just 2 or 3 minutes to discuss this, and we can go ahead and wrap up.
Did you say OD 6-year-old? Did you say OD 6-year-old?
Just tell them it's going to help them feel better. This is how they take it, and that's why it works. And it's not going to taste good.
So we have just a question. So just to clarify, so you've already so in this pretend scenario, so you've already counseled the parent, and then for both a 6-year-old patient as well as a 13-year-old patient, what sort of counseling points would you want to hit for the 6-year-old that might differ from the 13-year-old?
13-year-old.
Suck it up. You know better than to spit that shit out.
This pediatrics.
It's gonna make you diarrhea.
This pediatrics is technically 11.
11. I just go on like the topics.
You're missing something. mom.
Yeah, but it's not important. I don't have the complex cases is all. Like everything else.
Yeah, at 13-year-old, you could probably say you have some bacteria in you.
Take it. Don't be a baby.
This will kill the bacteria.
Yes. They can flavor it for you. I love when people come to the pharmacy and want to get stuff flavored. I just like Huff, the lemon flavored one. It is so good. It smells so good.
We don't have Depakote like in our pharmacy, but we used to have it at my pharmacy in Athens because I worked at the psych hospital, and I freaking loved every time I had to give someone Depakote because it smelled so good.
And Benacar, it's like,
But I mean, of course, I think potassium.
yeah, the yellow potassium, like the 10. Those
Yeah,
are good.
that one smells pretty good.
And they're pretty. If I was a child, I would eat that and the Bentil. The like lightning blue ones. They're beautiful. Look like they taste good.
Gosh, I can't remember which one it is, but I'm always like, that's a good capsule. That's a good looking capsule right there.
All right, well, discussion is dying down here and against us, so we'll just go ahead and finish off this presentation. So, what sort of things would you want to consider when counseling a 6-year-old patient, which is honestly the highlight of this job. So, for a 6-year-old patient, what are the things that you would want to address, or what are the things that you would want to tell this patient?
You can tell them like an age-appropriate language what it's for, and then it'll help them feel better. And like a 6-year-old can probably take it themselves. They just need to be supervised by mom or dad, make sure they're doing it right.
Yeah, I completely agree. So, and I think kind of the key word that you put in there, age-appropriate, is very difficult to assess in kids, but that's kind of part of the challenge with pediatric pharmacy. But yes, I do think explaining what the medication overall is being used for. So if you have not something wrong with you, but this is going to help you feel better. So those things that are, that brought you here, this is what's going to help prevent you from coming back, and this is what's going to make you stronger. I like to refer to Captain America, how they inject that stuff into him, and it makes him Captain America. So I like to refer to that. So I like to refer to it as that serum. So it's going to make you strong. But yeah, just kind of my own personal swing on it. So what about a 13-year-old? What would you start thinking about, like a teenager, in regards to counting points?
If they're not used to taking large tablets and they have some difficulty swallowing the tablet, they can ask a parent to cut it in half.
Yeah, very good. So kind of trying to do what you are able to as a healthcare professional to ensure that they are receiving their medication. So yeah, reaching out for that help to ensure that they are receiving the appropriate dose. Yeah, that's a very good point. Any other thoughts? And so again, I think kind of one of the key words is age appropriate. So kind of explaining it sort of in a more mature language, what it's being used for. So you have an infection in your ear, and this antibiotic is going to fight off that bacteria that's been causing this infection. And I think kind of at that point is when you can also reaffirm that it's really important to take this medication and not only take it, but take it to its full course. It's going to be best if you take all this medication as it's prescribed. Any other last minute thoughts on these scenarios? Okay, well that is all I have for you guys. So you're getting out of here a little bit early. Did anybody have any questions about anything that we talked about? Anything that's still unclear? Do you guys want more practice with any drug dosing scenarios for pediatric patients that you think would be beneficial? Any questions about pediatrics as a whole or residency or anything else? If not, my email is on here. Feel more than free to reach out to me. And it has been a pleasure being with you guys. And I think I'll be with you later on in November as well.
I have a question.
Sure, yeah.
So for the exam, would you be giving us like a lot of information, like lexicon information, as far as those, or do we have to memorize that, or?
So I will clarify what my responsibility for the exam is. And I'm assuming you guys don't have like resources available to you when you're taking exams. Okay, so yeah, if it was something, it would be a very reasonable question. And again, I'll clarify what sort of questions I'm responsible for. And if so, then we would give you the appropriate information that you would need to accurately answer that question. And then I know there's questions about the previous lecture that got canceled because of the hurricane. I think there's still discussion in regards to how to make that up. So it's a pharmacokinetic lecture in regards to pediatrics, so it's going to be a little bit more math, a little bit more intensive. And I think they're still trying to figure that out, so I'm sure communication will be coming shortly about that. Well, thank you guys. Have a great rest of your day.
Thank you.
Thank you.
Yeah.